It's working.
Okay.
So good evening, everybody. My name is Ruby Curtis. I'm a rural GP in Cooma, which is in the snowy mountains of New South Wales. So tonight we're interviewing Dr. James Allen, who founded the Orbona Foundation. But firstly, as I sit on Narragaow country, I'd like to acknowledge the history, culture and diversity of all Aboriginal and Torres Strait Islanders and recognise their continuing connection to country, to the land, waters and community. I pay my respects to them and their elders, past, present and emerging. So if I can introduce Dr. James Allen, who has a very impressive CV. James has completed degrees in both medicine and law at Monash University. He's a fellow of the Australian College of Legal Medicine and the Royal Australian College of General Practitioners and an Australian Associate Fellow of the College of Health Service Managers. But I also know that James, after the suicide of 2 LGBTIQ plus patients in 2001, founded the Orbona Foundation, which is a not-for-profit organisation that James will tell us more about. And then looking further into James's work, I see that your research in 2023 found that a quarter of the GP workforce in Australia attained their primary medical qualification in a country that criminalises homosexuality. So, James, I have a huge list of questions, but please feel free to go off on a tangent and tell us about any relevant aspects of your journey to the here and now.
Yeah, thank you for having me.
It's our pleasure. You've had a meandering and very unconventional career path with qualifications in both medicine and law. What motivated you to study these two things together?
So I guess that's a little bit like a question that we've all been asked at one point in time, and you sort of learn what people want to hear when, back in medical school, when they asked you, why did you decide to do medicine? And I think, like anything that's really hard, you need about 14 different reasons, because the moment you start, the first 4 will drop out and the rest will fluctuate all the way through. But probably one of the really defining things for me is a little bit unusual, but because my childhood was so, at times, involved quite a degree of terror and feeling that the world was a very uncertain and unsafe place, there's definitely a motivation to try to gain as much information and knowledge and exert whatever control that I could, which hasn't worked, but I think that was definitely a motivating factor for crossing several fields, just not wanting to have anyone know more than me about something. Yeah, and I think that took a long time to, it's still probably there a little bit, but yeah, it's an unconventional reason, I think, for doing what I did. That being said, at times I think it was absolutely an excellent decision, and other times I just think, oh God, no, that was terrible. Why did I do that? I should have just gone on a more conventional sort of a channel. Yeah, so that'd be probably a really influential part for that. And I think it's just what I didn't understand about studying law is that there are just so many interesting concepts, or the principles that we learn in medicine when you're looking at principles in law, even some of the areas of law that are really quite dry, some of the principles are actually very, I guess, philosophy based, and it can be really useful to give you that sort of structure for the way that you see the world.
That's a great answer. And then what was the pivotal moment in your career that motivated you to work mainly with LGBTIQ youth?
Mm. Well, for most of my career in the early days, I was really very eager not to be in the area of queer health. Um, I think there was part of me that thought, well, why would that be an area that's any different to anything else? Why would you sort of need that? And when I graduated, I sort of pretty rapidly gravitated towards rural and remote work because for me that felt exciting and novel, and you sort of had enough of the everyday sort of presentations mixed in with a little bit of fear and terror along the way, when a crisis would come into the hospital or some, major trauma would happen. It was quite thrilling and
Mm.
exciting. And I think in some ways, when you sort of have lived your whole life on edge, always worrying and sort of waiting for what's to come, sometimes when a crisis happens, that's the first moment that you actually relax. It's like, oh, it's here. This is what I've been on edge for. Um, but after about 10 years of rural and remote work, um, I had come back towards the East Coast to be closer to family. And I was doing an anaesthetic registrar role. And then I had an optic neuritis that knocked out my left eye for about 12 to 18
Oh,
months. And after that, I ended up doing a sort of like a return to work process. And the easiest place to do that was in general practice. And that is how I came to end up working in a primarily LGBTI focused clinic. As I was working there, um, I think perhaps because I could be fairly attuned to, or I guess what I would say is, when patients come in and see us, you don't know what healthcare beliefs or fears and anxieties are playing in the background.
mm,
And that can be operating whether you're aware of that or not. And even if you think like, oh, hey, I'm an approachable person, why should anyone be, apprehensive about, having a consultation with me? That's not what counts. What counts is whether or not they feel apprehension for whatever reason. And, for a great deal, many people who have had these experiences where they might grow up in families or communities with high rates of prejudice, they're on constant high alert. They don't want to be accused of being gay, or, they don't want to risk their parents finding out until they've gathered enough information to see how they think it might play out. And, even for some who do, there are very real consequences where bad outcomes that they were worried about come to pass. So my point is that in my clinic, I was always kind of pretty aware of, or tried to be aware of, um, when people were apprehensive about trust and what they could expect. Obviously, it helps when you're in a clinic that's very much focused on that area. But even then, it creeps in little ways where, I don't know, I guess it can be really mildly terrifying seeing a doctor if you're not from a medical family, especially for adolescents and young adults branching out into the world for the first time. So, yeah, I guess I accidentally accumulated quite a sort of degree of mental health caseload, and everyone in general practice experiences that. But the concentration and accumulation of mental health presentations when you're working in an LGBTI clinic, pretty much, you're seeing, high rates of people who will self-harm or high levels of suicide risk, lots of emotional dysregulation. And yeah, I think that was one of the really important things that got me interested. I think I tend to only be interested in things that seem novel, exciting, or difficult. So maybe that was why that sort of drew me in a little bit.
It was meant to be, I think.
Yeah, a little bit. Although it's very hard to keep yourself, take care of yourself in that kind of context as well.
So with your medical and law degrees, how have you been able to influence the healthcare and legal rights for our LGBTIQ community?
I guess I'd sort of say fairly, only a modest amount at this point. Like, a lot of people have done a lot of amazing things long beforehand to get to where things are now. The activism through years of decriminalisation and HIV pandemic, those sorts of things. I guess the bit that I can kind of contribute is really around the language of child protection through the lens of LGBTI health. And so basically this idea that if we think of one of the largest causes of excess mental health mortality and morbidity in LGBTI youth, it's their exposure to homophobia or prejudice, and that can be occurring within the family or also within their own community. And for them, it feels normal because they've been immersed in it the whole way along. And yeah, trying to give people a fresh look at that and to understand how very elevated levels of stress and anxiety during those developmental years has a profound long-term impact. And so then looking at that as a public health target point so that we can be, rather than waiting for people to reach out for help, whether that's when they gain independence from their family or community, or even if things have gone well and they've reached out, it's about winding that clock back and thinking of prejudice, anti-LGBTI prejudice, as a legitimate target point for a public health strategy, from maternity care, antenatal clinic, right through the life cycle of a family's contact with healthcare. And in part, that's trying to correct misinformation and to give the most accurate and relevant medical evidence. So that's kind of the little bit that I think I can contribute somewhat.
Sounds big, but so how do you see the landscape for LGBTIQ young people with their rights in the coming years? So for me, the gender affirming care for young people is what really annoys me at the moment. The Queensland government's put a pause on gender affirming hormone therapy, and there are also issues within the American military. What do you know about these things?
Yeah, look, things in America have been heating up for a while. There are certainly individual states that have made various laws or intend to create various laws that really do target LGBTI people. I think from an Australian perspective, there's a couple of things that hold us in, I think, a little bit more of a hopeful sort of position. The first is compulsory voting. I think that helps keep our politics more to a moderate middle. I also think that the marriage equality survey holds our community in good stead because there's a public commitment to a very important change for the equality of LGBTI people. And I also think it's really important to, in the Australian context, to think about people in categories and who is interested in these topics, motivated to, or maybe not so motivated to actually access information, but who are willing to receive accurate, brief information. And so when it comes to gender affirming care in particular, I think when we explain to an individual person that puberty blockers essentially hit the pause button on puberty, which allows children and adolescents, parents and families, gives everyone time and space to make what is a very complex decision, and that it's important to oppose the misinformation that initiating puberty blockers is somehow being done as coercion. It's not. It's a decision that, in its most simple form, hits pause, allows people to decide and what the next steps will be. So, yeah, and I think anyone who sort of reflects that differently, we need to ask what their motivations are. And then the second thing I would say is that many of the hormones that are used in gender affirming care are really just very similar to what a bodybuilder might be using surreptitiously, or, you know, in terms of testosterone, or for those who sort of accessing, you know, estrogens and whatnot, they're pretty similar to the contraceptive pill or, you know, hormone replacement therapy in menopause. And so if there's different levels of amplification of side effects or other information relevant to those medications, you know, I understand children and during puberty and all of that is very important, but, you know, putting it in context so that people in the community can understand, it's like, oh, okay, well, that's not, doesn't seem as big a deal. Yeah, and then in terms of human rights more generally, I think it's a really worrying time. But I don't know that I can do anything about that. You know, I think it's a question of how do we build empathy? How do we connect with other people? And, you know, certainly when I'm talking about LGBTI health, you know, if we view one particular part of the community as and engage with them in a hostile way, you know, even if there is a high degree of prejudice within that community, in the end, it's probably not making the best contribution that we can, because we know that that's where the queer children who are experiencing the most preventable harm, that's actually where they live. That's where they exist. And so if we can't find a way of connecting with those communities, whether it's through community leadership or discussion with parents and families, and if we can't acknowledge people's experiences and fears and apprehensions, I don't know what you're like, but until I feel like I've been heard, sometimes I can't concede to another person's point of view. And I think that's a really challenging thing to do in our society at the moment with, it's less human to human connection, and online, I think there's just I try to avoid it as much as possible.
So what have been your biggest challenges that you faced working with LGBTIQ plus youth? But then on the other side of the coin, what's a success story that stands out?
Mm. There's a couple of things that are really challenging that come to mind. The first is that sometimes people will want to tell you their stories, and that's great, and I understand why, and I'm often there for that, but sometimes it's not the right time for me. And so, um, I guess learning how to foreshadow the need to kind of have a conversation about, I can't hear a traumatic story right now, you know, whether that's, I guess we've all been in those moments where you might bump into someone into the supermarket and it's like, oh, this is not the right place for a conversation. It's
Yes.
that sort of thing. Um, I guess the other, when I try to speak to organizations who I'm trying to persuade or educate around LGBTI health, that can expose me to some really harmful views sort of directed straight back at me. And I'm not talking about views from an area that sort of people might anticipate. I'm sort of talking in the sort of medicine and health space where, and I understand that we need to be driven by evidence, but there are certain things that are quite complicated to prove. And some of those are in the category of prove that you're normal. And I think that that's one of the challenges around healthcare for trans and gender diverse people. There's always that little bit of, well, prove that you're normal. And it's like, or, prove that these people exist and that's not pathological. And they're really challenging conversations to have. But if people are talking about it and asking those questions and having the discussions, I'm happy to kind of be there and participate. Sometimes it can be really, really hard.
Mm.
And I don't have the answers for all of these things. Sometimes I just think, well, maybe I contribute one little piece of whatever their overall journey is about learning about this thing, and where they land in 10 years' time might be very different to where they're at right now. And then, oh, one other really interesting and difficult thing is within any traumatized or disadvantaged group, not everyone has, there's no completely homogenous view of things. And so there can be horizontal violence between different groups within the LGBTI community, misunderstandings and miscommunications and invalidation, which can be very tricky. And so sometimes I'll walk into a swinging door in a space where I thought that I wouldn't, so I didn't kind of have any defensive armor up. And you can sort of land flat on your face a little bit with that. But the flip side of that is, so if we assume from the marriage survey that about 60% of people voted yes and 40% voted no, those people all have children. And so you might have 60% of gay men who've grown up in a relatively accepting environment and space. And then you might have 40% who grew up in difficult circumstances. And all the ones who didn't, look at all the ones who did, and they don't get it. They're like, why do you have so many problems? Or why are there so many challenges for you? And of course, because the lineage of the queer community, it's not a vertical lineage, so we don't get to educate the younger generations as they come through. But yeah, trying to find a language that helps the different groups understand and get each other and sort of increase the acceptance within our own community as well. Because it's really tricky. We're all exposed to the same media and mixture of views and opinions along the way. So yeah, that can be a really challenging thing to handle.
So should we get on to your Orbona Foundation? So what are your core objectives or specific programs or initiatives?
Yeah, so the organisation, the primary purpose is to prevent harm and advance the welfare for LGBTI children and youth. And there's a secondary purpose for adults who have ongoing, excuse me, for adults of the same community who have ongoing challenges related to their experiences in childhood and adolescence. And importantly, that specifically includes children who haven't divulged or made a disclosure to anyone about their diverse identity, because the primary strategy for a lot of kids who are in unsafe environments and that they know there's a lot of anti-queer prejudice is to actively conceal and blend in and try to avoid any negative consequences. So, and if we think that gender and sexuality develop probably on the same kind of timeline and continuum that we would expect for heterosexual and or cisgendered children. There's no reason to believe that those timeframes are any different. One of the major causative factors of, there will always be a delay in coming out until people feel safe enough or have enough independence. So yeah, they're the primary objectives. In terms of where I would like to go from here, at the moment, I'm very much in need of a prolonged holiday, but I would like to look towards increasing some kind of public health information in GP clinics, a place where it's more mainstream, not an LGBTI dedicated space. I don't think that that's where I would be best most useful. So it's about trying to get a range of information that is going to be a conversation starter in GP clinics, even amongst staff, but also many parents have it's never crossed their mind that their child could have a diverse gender or sexuality. I would also love to see something in the child health handbooks, because I think that's a really useful space to be in. And yeah, trying to find straightforward ways to explain to parents and families who are just genuinely motivated by the best interests of their children. Yeah, so that's where I'd like to go from here. I'd like to do a little bit less of sort of the policy submissions work that I've done over the past couple of years, and focus more on something that's a little bit closer to the coalface.
So what resources would you recommend for parents, GPs, children, teachers? What do you think are the three best sources?
Yeah, I think that's a really tricky question. It depends on what the issue is. I guess when it comes to the broader idea of stress and challenges experienced by children and adolescents, for clinicians, I think Bessel van der Kolk's book, The Body Keeps the Score. I think looking at understanding trauma is going to be increasingly important for health outcomes in the future. And, understanding trauma, not just as capital T trauma, the big ticket items. Sometimes it's the maybe less intense but more pervasive cause of stress that really challenges people. And yeah, so that's probably what I would say for practitioners.
Yes.
Yeah, and I hadn't actually thought about anything for patients and friends and families. I have to take a pass on that one.
So with the Orbona Foundation, how can individuals and organisations support the work that you're doing with the foundation? How can we help?
Yeah, so people are certainly welcome to reach out to me through your organisation or through my website, orbonafoundation.org. There's no AU at the end of that. And so at the moment, I've just been connecting on an individual basis with people who are interested and motivated. Yeah, but also there'll be a period of at least a couple of months, I think, of rest and recuperation for myself before I embark on things. Things over the last couple of months have just been very challenging. With everything happening in the US and Queensland, there's been a lot of intense kind of interactions with people. But yeah, so people are absolutely welcome to reach out to me. And in the future, once I'm looking to put things out to broader practices and clinics, then I'll probably just try and sequentially do that, probably starting in Queensland and working my way out from there.
That sounds great. We look forward to that.
Thank you.
Do you have anything else you'd like to share with us?
I guess when it comes to, the hot topic at the moment is around gender affirming care. And it can be tricky to determine the right level of response or intensity. And I think that in what a lot of people see as quite a niche area, it's actually really super handy for every doctor and healthcare worker to have some familiarity about what it's about so that they can demystify this concept of gender affirming care, where they conflate puberty blockers, cross-gender hormones, and surgery. And when they conflate those three together, they make it sound like 12-year-olds are coming home with gender reassignment surgery that their parents had never been consulted over, which we know is not true. But if these kind of ideas are propagated, it's very easy for reasonable people to be misled. And trying to displace that with straightforward conversations that are easy to understand, and that probably starts with all of our workplaces.
I don't have any other questions. Anyone else watching have any queries?
I'm just so impressed with your passion and your interest and your persistence in this, and I'm seeing a level of burnout, James, and I'm so pleased that you agreed to go ahead with this interview, which was delayed by a few months because of the storm event in Queensland last year, because it sounds like what you really should be doing is being on holiday yourself, so I hope you do that. As a GP, I do have a few patients who are at various stages of gender journeys. It's something I'm personally supportive of, but don't actually have any experience, nor at my stage in career, right towards the end of general practice. I don't feel it's appropriate for me to be seeking further training around that. And I'm fortunate that there's some local GPs who are able to take on that load. What I'm really sort of, where's this coming from? I really can't see it's that it's easy to get the experience to actually be able to take the next step. There's one thing to be affirming and say, you are who you are. I respect your identity as who you are. And for some of my patients, they're really not sure. And I've had a few primary school students who have sort of switched across from identifying as the birth gender to identifying as the other to then being a non-binary situation. And I'm just wondering, what resources there are for where you would send a general practitioner just for education as to what the next steps would look like, and whether there's any really easy educational resources for us to just get our heads around the simple steps.
Yeah, really great question. And so many thoughts have come to mind. The first is that AusPath is the organisation who developed the Australian guidelines that are more recently have been, it's been indicated that the NH and MRC will be reviewing those guidelines and providing new ones through their process. But yeah, AusPath is the organisation of healthcare workers who are involved in gender affirming care and care of trans and gender diverse populations. Any of their listed clinicians would be happy to take a phone call from a GP, whether that is about supporting someone who is providing care directly, or whether it's around finding what the referral pathways are. They're a great organisation to start with. A couple of other things crossed my mind as you were talking. And when I'm speaking to medical doctors who are supportive, but they're not really familiar with either the community or a particular area, I always say, and this is what I would do in my own practice, if a patient came in, either I knew that they had a history of quite a lot of trauma or just sort of acted in a particular way, I would sit down and I'd say, I'm very, very supportive, but I don't know everything. And even if I did, sooner or later, at some point in the future, there will be a moment where I say or do something that you'll find is really disruptive. And you might not know whether I'm a friend or a foe at that point.
Mm-hmm.
And even if you can't bring that up with me at the time, if you can find a way, even though it's not your job and you shouldn't have to, but if you can let me know, I promise you I will do my best to hear and understand it at the time. And I apologize in advance if I screw that up as well. And it's been incredible how that has saved a therapeutic relationship 2 years down the track. And I sort of learnt to implement that a lot through dealing with traumatized people. We shouldn't be surprised when traumatized people behave in traumatized ways. And, in fact, it's the most likely thing to happen. And I know that there's moments where I can get very disoriented as to, in that very black and white thinking, with me or against me or whatever. And, I think having that just allows a little bit of space for that conversation. And, I also think that it's absolutely okay to provide someone part of care that you can contribute to and then help facilitate others adding their own input. But the referral pathway, if there's ever someone in the network will be able to help solve a problem, or someone who reaches out. So either through OSPATH or ringing the gender services clinic at one of the major children's hospitals, and to a lesser extent, adults. I think practicing gender affirming care for adults is just less politically intense. So, yeah.
Thank you.
A couple of
That's
thoughts.
really, really useful. I like the fact that you almost apologise in advance. That you say right out, I'm human. I might stuff up. Forgive me, and know that if you call me out on it, I'm going to do my best to make it right. That's a really good way to approach a lot of tricky situations, I think. And thank you for pointing that out.
Yeah, I can't count the number of times where I've had such enormous relief from the moment of realizing I just don't know something. Rather than pretending like I have to. Yeah.
But I'm remembering the most recent one. I've still got a good therapeutic relationship with her. Almost 12 months since she started transitioning, with a GP who's just down the road, and she's got sees the GP down the road for all the gender stuff and sees me for a lot of mental health and other general stuff. Maybe it's a little bit irregular to have two GPs, but it works for all of us, I think. And I've been looking after this kid since she was a bump.
That's interesting. Yeah. Reminds me, when I was working solely in an LGBTI focused clinic, almost every single one of my patients saw multiple doctors. But that's being in a metropolitan area where people can divide their care up the way that they wish, and it's not always, a frustrating fragmentation. Sometimes the patient is deliberately sort of fragmenting their care, so they can see their local GP for the things that they feel comfortable with, and then the things that they just feel they need that little bit of extra certainty that they're going to be treated with gentleness and kindness, or they're just worried about stigma or whatever it is. So I think,
I guess patients have always had the ability to choose a different doctor for a different problem, and that's our specialty system is a formalisation of that. But within general practice, there's kind of an expectation that people will have a clinic or have a GP and stick with them, and we, as GPs, tend to feel we're not providing holistic care if we're not providing the full service. And I think that's just a little bit of an issue that, maybe it's my mindset that's the problem, because I feel in a way I'm letting this patient down by not having the full armamentarium at my fingertips, and that I've had to send her down the road to get the right advice and just the nuanced treatment that I just wasn't across.
well, it sounds like you put a lot of care and effort and diligence into what you do. And, forgive me, it might be a little bit of a generational thing in terms
absolutely.
of, the changes that have crept into general practice, many of them not that desirable. But I think continuity of care is so useful. Whenever I think of barriers of shame, continuity of care is required to tackle shame, because if you're not seeing the same person, then the relationship isn't evolving to a place of trust. And I think that's one of the really important things that we need to think about when we design our healthcare systems. This idea of continuity of care might not be as prioritized as it once was, but it's so important. And just thinking that for operational reasons, you can just see a different doctor all the time, the outcomes aren't great.
So I had a different question. Can you hear me?
Yeah.
Hi, it's Melissa Robbie here. My son wanted me to raise this with you. He's very concerned that although there's now results that show that lenacapavir as a injection, I think 6 monthly or something, is effective prophylaxis against catching HIV, but that there's no funding for this.
So I don't have any personal experience with the injectable versions of pre-exposure prophylaxis, but that's a really great question. And I had forgotten about PrEP even as a topic. So thank you for bringing it up. The injectables, what I knew was that experience in overseas jurisdictions for treatment of HIV was very much welcomed by particularly women with HIV, because it allowed less regular attendance, and it's easier for that to be a more discreet process for people. Injectables for PrEP, yeah, I'm not 100% across. I do know that there was a challenge with what that would mean with any depot injection as the depot dose is trailing off. You're essentially having, potentially subtherapeutic levels for a prolonged period of time. So I know that was one of the barriers.
But I understand there's now been a large-scale trial that showed that it was fully effective.
Yeah, and I'd heard similar, but I haven't looked into it specifically because
the problem is no one seems to care that there's this fabulous. The drug company's charging like in mega bucks for it, but it costs like just a few dollars to produce. So in theory, we could be treating all of Africa with occasional injections and get rid of HIV transmission, but no one's doing it.
Yeah, I think that'll be a game changer over there, and certainly it's an important thing to be funded. Obviously, the patent system with the World Trade Organization, and I do have some funny stories about that. But getting back to the Australian context, we have been doing quite well with oral PrEP. And I think it was last year was the first year that there was zero transmissions of HIV in Sydney. And, Australia in its very unique setting, there are hopes that we maybe could become the first country to have zero transmissions and/or eradicate HIV.
Yes, I suppose you only need a certain percentage, depending on the math, the number of sexual partners, etc. You don't need everyone to be fully protected to get the herd immunity. It's not herd immunity, it's herd resistance.
Yeah, I mean, it's really interesting. There are charts, in particular. What's the ASHM, the Australian Sexual Health? I can't remember. So ASHM do a lot of training around HIV, hepatitis, and the prescription of antiviral medications. So GPs can do a course and get a license to prescribe HIV medications, or they can do another course and get a license to prescribe hepatitis medications. And so there are different cohorts of GPs where they do that to provide that extra service to their patients. Where was I going with that? Oh, that's right. ASHM have some really great data on the rates or the percentage risk of an individual potential exposure to HIV, and that helps to guide post-exposure prophylaxis. And of course, the data in Australia is very different to the data in other parts of the world because it's affected by the background probabilities.
The prevalence of HIV.
Yeah, but also when people are on treatment and they have an undetectable viral load.
Right.
Yeah, that's now considered to be untransmissible. And, so I think all of that works together quite well. But yeah, the injectable prep, that I will brush up on that for future. I was really, I'd forgotten about that as a topic. There you go.
That's my son's whole concern, is that no one's talking about it. Like, there needs to be outrage and thumping on the doors of the pharmaceutical companies, and
Yeah, I think it's
God
really
knows how many
challenging.
people in Africa are dying as we speak.
Yep. Yep. Keeping that international perspective on things can be really challenging, but also conserving some of our outrage and, you know, sticking to what we can do. Yeah. But no, that's interesting. Thank you for that
Well, I think the
question.
first thing is like to keep it on people's radar, you know?
I think it is. I think, you know, a lot of people out there are really putting a lot of effort into these things. So, but it sounds like, you know, if you've got a son who is highly motivated in that area, well, you know, there's the International AIDS Society that do a lot of good work in this area, and you can, as a medical doctor, become a member of. I think other healthcare workers can as well. You know, so that there are a lot of people doing a lot of work in that. I guess we all just gravitate towards our particular niche.
Thank you.
Well, any other thoughts, comments, feedback, suggestions?
I'd like to thank you for all the work that you're doing. And yeah, it is apparent that it's like who treats the doctor, you know, who helps you to debrief, etc.
Yeah, self-care is very important.
I reckon it might be time for Ruby to wrap up and we can turn off the recording, and anyone who has any further little supportive comments can carry on. We've been together for an hour. I can't believe it.
Well, thank you so much for having me along. I really appreciate the opportunity, and I'm a little bit rusty, I have to say. I was a little bit anxious coming in tonight because I don't know, it's been a while since I've yeah, at least a month. So I was like, oh.
Well, hopefully it was a fairly gentle step in. Just one question I had before we switch off. I'm looking at those banners behind you for your foundation, and you know, the one on the left, you know, is a space in your faith to love and accept all children. Are you finding that there's a really big religious push against acceptance of gender?
Ah, okay.
Sorry, I've actually started up a new conversation. I apologise for that, but I couldn't.
No. I guess one of the things I always come back to is that the parents of people who have died by suicide always wish that they knew back then what they knew now. And, you know, taking the example of sexuality and, you know, generalizing that to diverse genders. You know, people who were born in the 70s and 80s were in the shadow of criminalisation in Australia and or pathologisation, you know, in the DSM. So when every institution in society has taught parents and families that if they in any way detect that their kid could be gay, do whatever you can to prevent it. You know, and that messaging was coming from Parliament, judiciary, police, schools, religion, and in a lot of ways, healthcare. And so within that context, parents might see what they perceive to be a trait that could be indicative. And, you know, the reality is there's stereotypes for a reason sometimes. I don't want to kind of get into that debate. But if they sort of sense these things and they do what's within their toolkit to discourage it or oppose it, even when that person comes out and the family go on that journey towards acceptance, that's kind of happening in that kid's like adolescence or adulthood, early adulthood usually. And it can kind of never take it all back. It can't erase the, you know, immersing a kid's central nervous system in, you know, a lot of stress. And so when it comes to diverse gender, I feel like a lot of parents, they just kind of see it and understand it with their child. And there are obviously cohorts that might be quite philosophically opposed or resistant. But then there's a whole lot who are actually happy to do whatever they can to figure out what the best interest for their kid is. Unfortunately for them, sometimes other people in the community then treat them like they are a child abuser. And so that's where misinformation in the community makes it hugely unsafe for these parents and families. And, you know, it's the ones who, you know, it's infrequent enough that there are many communities where people have no exposure to someone with a diverse gender. And that misinformation becomes really dangerous when this intensity, all of this political heat is then applied to an individual person, and, you know, family and community. You know, and as we know with decision making for children, the decisions have to be made in a clinically relevant time frame. So if transgender and gender diverse people exist, then certainly children who are trans or gender diverse exist, and they need healthcare provided on a timeline that's relevant. And if that is delayed beyond puberty, some of them will have irreversible, unwanted changes of puberty. And yeah, so I think it's I guess a little bit of a, yeah, there's just different clusters or aggregates of what I've seen over time. And there's definitely some families who absolutely reject it. And, you know, I can understand it's tricky to process new information. And, you know, most people in the end are coming from a place of wanting to try to do what they think is best for their child. And defining what that is can be hugely difficult sometimes. You know, in the ideal world, there would be enough freedom from prejudice in our community that people could express their gender however they wish without anyone finding that disruptive or disapproving of it. You know, I guess that's the paradox of gender affirming care sometimes. You know, we want to see people achieve self-acceptance, but we also live in a real world. So actually, I traveled recently with a friend of mine who is trans, and moving through the airport, the airline staff couldn't look her in the eye as she was checking in, and going through security clearance, like everyone kind of, because they are trans, but you know, because of their features, they stand out. And so every day they are stepping out into the community, educating everyone all the time, just by living proudly in the way that they can. But yeah, it was a real insight to see the world through their eyes. Anyway, I could talk your ears off all night. We should wind
So
up.
those pioneers just have my absolute awe, because it's just such a hard journey to step onto. But everyone who stands out there and wears their identity with pride is going to be helping to educate the rest of us to feel that that's a normal part of being human.
Yeah, I remember what at university, in my college, I was the first person who was out. And in my medical school, I was the only person who was out at the start. And yeah, so I mean, it's great that things have come so far from then, but yeah, the 90s, you know.
Ruby, are you happy for me to close up the meeting now? Would you like to say something to close up?
I'd just like to say thank you very much, James. There are a lot of interesting insights, and then you've got your personal aspects and touches that have come with it. It's been very enlightening, and thank you very, very much.
Thank you all for having me. I'm really appreciative.